Greetings, thank you for coming back promptly after coffee. I'm Amy DeMarco. I'm an endocrine surgeon here at the Hammersmith, and I'm joined by my colleague.
Yeah, I'm Shiva Jarvis, an endocrinology consultant here. I'm a researcher, and so thank you for coming back to session 2, and we'll kickstart. We'll love to introduce Professor Vibeke Alt, who's obviously introduced us herself earlier, but we're really grateful to have an expert talk. So she's going to talk about urine steroid metabolomics, what it is and how we can implement it. Needs no introduction, but you're the director of LNS, MRC, Professor of Transdisciplinary Research and Consultant Endocrinologist. So thank you.
Thanks so much.
To you.
Okay, cool. So like urine steroid metabolomic, what is it and how can we implement it in an NHS pathway? We do a lot of stuff with urine steroid metabolomics, but I'll talk today about the ACC test. So steroid metabolomics is the combination of mass spectrometry-based multi-steroid profiling with machine learning-based processing of the steroid data. So the two of them have to go together so that we really call it omics. Yeah, otherwise it's just like steroid profiling, multi-steroid profiling. And so it is in a way a targeted technique, yeah, like sort of next to global metabolomics, but we also do now like more targeted lipidome profiles or other metabolome profiles. And this is like a specialized steroid application. And we do this anyway in any biological fluid, but we stand in a fantastic tradition by doing this in urine. So this is the innovation we bring to you. Urine testing, you see it's around for a while, yeah, like sort of, so like one of my mentors, he had to still as a SPR taste the urine to, to see how diabetic they were. We didn't have to do this anymore. Yeah, like, and fascinatingly, you can capture, and this was initially done with gas chromatography, mass spectrometry, everything we excrete and produce in the adrenal, all over the body, in the gonads, in every tissue that is able to synthesize or metabolize steroids. Yeah, and obviously these are profiles of adult steroidogenesis. So you see, we do a lot of active sex steroids, both in men and in women. And you see over there in orange, these are the glucocorticoid metabolites that are excreted. So that's a majority of what we excrete. It is much, much lower, the central precursors, the mineralocorticoids in green and the glucocorticoid precursors in yellow. So these circulate in much lower levels. And this actually, this method has been pioneered since the end of the 1960s. And actually, he was appointed 1969 to his first independent research group here in this institute by Cedric Shackleton. Yeah, and this is like the cake we did for him for his 80th birthday symposium. So this is a GCMS. So like, so he was completely bowled over when he saw this cake, and it was very tasty. Yeah, like, and and I tell you today about how we apply urine steroid metabolomics to adrenal tumors. And obviously, you know everything about adrenal incidentalomas, and this is a wonderful paper by Irina Bankos, where she showed that actually over the years, the number of incidentally discovered tumors goes up and up. Patients that present through cancer or through hormone excess stay pretty much the same level. But as we do more imaging, and currently we do in the UK 7 million CT scans, yeah, of chest and abdomen per year, and tendency is going up, yeah. And 5% of these chest and abdomen scans actually show an adrenal tumor. Yeah, so that's a huge number of things. Yeah, sometimes the radiologists decide not to report it because obviously they weren't asked about it. But the larger tumors mostly make it to the endocrinologist or other people who look at it. When we have an adrenal incidentaloma, an incidentally discovered tumor detected on imaging that was not arranged for the purpose of suspected adrenal disease, then we have two questions to answer. So, is there hormone excess? Yeah. And is there malignancy? Is there cancer? And obviously that is very important to the patient. Yeah. So the patient has no understanding that the adrenal gland is a hormone factory, but they know, wow, I have a tumor, so that means cancer. But obviously it doesn't. But still, 5% of those patients that undergo workup in specialist centers are diagnosed with adrenocortical carcinoma. So hormone excess, we have relatively well-established protocols, how we exclude, we heard about primary aldosteronism, cortisol excess, androgen excess, yeah. But malignancy is definitely another problem, yeah. Like, and detecting adrenocortical carcinoma is obviously a priority, because if you fail to detect it in a timely fashion, the only curative option is surgery, then you delay this, and that is potentially fatal. Yeah, and obviously it's a devastating disease, and this is actually a woman with glucocorticoid producing and virilizing adrenocortical carcinoma I looked after as a medical student. So she gave consent for me to take the photo and to use it in scientific talks, because she wanted to show how she had to live. So she was like hiding at home, yeah, and on her way to die, because there were no treatments we could offer her. Yeah, so this is a highly malignant tumor, and despite great progress in the area, it still has a very poor 5-year survival. Yeah, and it is really difficult to differentiate adrenocortical adenomas from carcinomas. We cannot take biopsies. Often the pathologist struggles when they have the whole specimen, but like from one little biopsy, they will only tell you it's adrenal, but they will not tell you if it's adenoma or carcinoma. Yeah, so like, and in imaging, you have like, you can say, oh, if it's big, it could be carcinoma. And you see here the results from our large prospective study that recruited more than 2,000 patients. And that's generally true. On the right side, you see ACC, loads of them are big tumors. But you see also on the y-axis the N number. These are small numbers. And you see here the adenomas. There are still a lot of adenomas that are more than 4 or 5 or 6 centimeters. Yeah. And so basically, in principle, the best cutoff is 4 centimeters. Yeah, because it gives you a high sensitivity of 98% and at least a specificity of 79.6%. Yeah, if you go above or below, then you'd have too many false or true positives. So that's a very important thing. Yeah, and so, and obviously the other thing we can do is to run an unenhanced CT. The unenhanced CT will tell us the difference between lipid-rich and lipid-poor tissues. Yeah, like if it's very lipid-rich, it will have a low Hounsfield unit. Yeah, after Jeffrey Hounsfield, who won the Nobel Prize for his work on MRI. Or it will be even negative if it's purely fat. And usually if it's lipid-poor tissue, then it will be high. Yeah. And but then it's not only adrenocortical carcinoma or metastasis or pheochromocytoma, but a large proportion of the benign adenoma also has high Hounsfield units. Yeah. And even a tumor we know to be very fatty, adrenomyelolipoma, can be lipid poor. And then we still stand there and do some major surgery, taking out half of the pancreas, taking out the kidney, and to be told, oh, wow, it was a lipid poor adrenomyelolipoma, and the surgery was not needed. And the cutoff of suspicion, which we established in the UNACT study published in the Lancet, is 20 Hounsfield units. So if you do 10 Hounsfield units, you do bad things to your patients. Yeah, like so because you have a lot of unnecessary investigations and surgeries. And so cool. So it's clear that we need novel biomarkers, and it is really nice to see how long things take to implement. So we are very close to implementation in the UK now, followed then by Europe. I mean, I talked to Antoine about it. And we published our proof of principle paper in 2011, and we started work on this in 2008. So it takes a while. So, and my hypothesis at the start was, at the time we only measured like cortisol, aldosterone, DHEA, and products of adrenal steroidogenesis. But I sort of hypothesized very simply, if this is a cancer cell, a dedifferentiated, non-mature cell, then it might not have the complete enzyme apparatus to produce the end products, but it might have just an aborted enzyme apparatus that will produce precursors. But precursors were not measured in blood. And 24-hour urine gives you obviously the opportunity to see everything that's about. So we recruited, with the help of NSAT, the European Network of the Study of Adrenal Tumors, 102 benign tumor patients and 47 ACC patients, all of which were histologically proven or had long follow-up radiologically in clinical. And then we did steroid mass spec. And I collaborated with my good friend, Michael Beale, who's a professor of machine learning in the Netherlands. And he used the steroid data to train and find out what is the difference between benign and malignant. And we were very astonished, but the outcome was that actually 9 markers were enough to differentiate, and it's a super distinct steroid fingerprint. And the majority of what is high are actually the precursors. What I showed you in the overview was very low, is very high in cancer. And this gave in this proof of principle study, not only 90% sensitivity, but 90% specificity. So totally superior to imaging. So we thought, wow, that's great to roll out. And while GCMS is a nice cake, you can produce you can process about 20 samples a week. So that is not a solution for the UK or the world. So therefore, the next thing we did is create a high throughput method, which meant that we transferred it from GCMS on the left side to LCMS on the right side. Yeah, and you can see that we get very similar results. Yeah, and when we test this with a machine learning method, it's a similar diagnostic performance. So we knew we could run a big study. Yeah, so at this point in 2015, we had achieved proof of principle, and we showed that there is a high throughput method. And then obviously I wanted to do a prospective test validation study. And then I talked to my good friend, John Deeks, who's a fantastic guy, world-leading statistician and diagnostic test specialist. And he said, well, I calculate this for you. And he calculated, and I gave him all the data. And then he said, totally good news, Wiebke. You only need 2,000 consecutive patients with an ACC rate of 5%, and then you can validate the test. Then I said to him, yeah, okay, so the largest study ever published was in JCM, 1,000 patients from Italy collected over 15 years. And I would like to see this implemented sooner. And then he said, okay, go for it. So I had to take him by his word. And then we said, okay, we do the networking approach. So we should go for it. Yeah, so we did the Urine ACT study, the evaluation of urine steroid metabolomics in the differential diagnosis of adrenocortical tumors study. This was a fabulous study. And Irina Bankos was one of the lead fellows at the time. She was postdoc with me in Birmingham for 3 years, and lots of previous fellows actually on this slide who now lead their own centers across Europe and the world, and we were able to recruit the required number of patients in 5.5 years. And it was an absolutely mega effort. And we had 4.9% ACC rate, which John Deeks okayed, close enough to 5%. So we were fully powered and could sort of answer questions. So this is actually the breakdown. And because we had this massive number of prospectively recruited patients, we had for the first time not only adenoma and carcinoma, but we had also other benign tumors and other malignant tumors, so non-adrenal origin tumors. Then a large number of those had unenhanced CT, yeah, and these are the results of unenhanced CT of the 1,328 benign adenomas in the study. And as you see, only 2/3 make the old cutoff of 10 Hounsfield units. Yeah, but 32% would have been suspicious of adrenocortical carcinoma with the old cutoff. But we could nicely demonstrate that 20 Hounsfield unit is the cutoff from now on we should use. It's a major outcome of the Urine ACT study. But you see still 17% left who are an adenoma, yeah, and still seem to be suspicious of ACC. We could show that by raising the cutoff from 10 to 20 Hounsfield units, we decreased the false positive in these 2,000 patients from 423 to 200 patients, but maintained 99% of the ACC patients true positive. Yeah, so it was only a single patient didn't fall into this, and this was a glucocorticoid producing patients who anyway would have been removed. And so in total, of the 2,014 patients, 565 underwent a removal of their adrenal tumor. And obviously we didn't intervene, we just accompanied observationally. And the results showed that 38% of those would not have required surgery because they were benign and non-functional, yeah, and that is a huge number. All of these patients underwent surgery. Some of them, I have to say, very major surgeries and not only endoscopic adrenalectomy. And then obviously to our urine tests, so the people in the lab worked very hard and measured the 2017 urine samples included in Urine Act. We did machine learning and then divided them in low risk and high risk of ACC. Yeah, and then the results were analyzed by Alice Sitch and John Deeks. Alice Sitch at the time did her PhD, but now she's professor. So you see how long it took to do all of this. Yeah, and so they compared in red the true positives and in blue the false positives, ACA, so patients who are adenomas. And what they could show if you do a single test only, so either tumor size, Hounsfield unit greater 20, or urine steroid metabolomics, you are indicated to have high risk by the urine test, then you bring dramatically the false positives down. And if you combine two tests, you bring the false positives down further while maintaining absolutely 98% of the true positives. Yeah, and so the final analysis said the optimum test is combining tumor size with Hounsfield unit on unenhanced CT and the urine steroid metabolome test. And this gives you this information. Yeah, if you are greater or equal to 4 centimeter diameter, have a Hounsfield unit greater 20, then a urine steroid metabolomics test will be absolutely excellent, weeding out all false positives, but giving you pretty much all true positives. Yeah, so the negative predictive value in the study was 99.7%. Yeah, and the positive predictive value was actually 76%, and for imaging it was 19%. Yeah, so like so it's a huge difference. So we published this, and obviously then there was great excitement, and there was an editorial, a multi-test strategy for adrenal tumors, and we were one step further on our historic landscape picture here. So we had now like a high throughput test that was prospectively validated in an international multi-center study. Yeah, but then still you need to bring it to the NHS. So how do we do this? Yeah, like sort of this is a multi-steroid assay with 15 steroids. So I talked to the top labs in the UK that are in routine clinical biochemistry, and they said, we can't do 15 steroids. Yeah, like sort of, and we need accurate quantification with standards and la la la. We can't do profiling methods that won't be approved. Okay, cool. And that was a very productive discussion because we came back together as a group and discussed how we do it and said, yes, we bring the 15 steroids down to under 10, and we will get produced dedicated NMR controlled standards for accurate quantification so that multiple labs that are capable of establishing the method can do so. Yeah, and that led to accelerate. Yeah, so, and I'm very pleased to say that we were amongst the 6% of people who were funded in the last round of Invention for Innovation at NIHR, and received it for the Accelerate grant, refinement and implementation of a rapid urine test for the detection of adrenal cancer. And this is a 3-year grant, and in year 3, it will be available in the NHS, yeah, if not earlier. And I learned a lot on this pathway because you need to pick up a lot of skills and meet a lot of people that have skills that you don't have. So like sort of, so you need regulatory people that do a CE marking of the test. You need integrated software that brings this clinical biochemistry results together with a machine learning algorithm. You need to talk to patients a lot and ask them, is this the right thing to do? We had fantastic support by AMENT and ACC Support UK. We did focus groups with patients who have benign tumors and malignant tumors, and we learned a lot from that, and that there is a great need for a test that is accurate, fast, and reduces anxiety in patients. Yeah, and then obviously to map out the health economics and the adoption roadmap, we did a preliminary health economics analysis, which they told us shows that the test is dominant. But I thought, okay, what does this mean? But apparently it means it's much cheaper. Yeah, like, and so that was good news. Yeah, so we put all of this together, and you can see all the people who are in here. And that basically came with us creating a spin-out company, which the government always wants us to do, yeah, which is called IMS Solutions, Intelligent Mass Spec Solutions, yeah. And so I declare a conflict of interest. I'm the Chief Scientific Officer of Intelligent Mass Spec Solution. It's a very tiny company. And this is Martin Whittaker, who is the Chief Executive Officer of Intelligent Mass Spec Solution, and I'm proud to have convinced him to come over from therapeutics to diagnostics, and it is absolutely fantastic to work with him. Yeah, so that means we are now like on our way to condense the test to 8 steroids with an optimized assay with NMR controlled standards, so that this can be rolled out in the first instance to the UK and to 3 centers that will measure all the samples from the UK. And then we have already European centers lined up. And I just show you a glimpse of new data that James Hawley, who's a PhD student with me and a biochemist in Manchester, will show at the BES in its entirety, because we did one thing: we compared urine against serum. Yeah, because some people have said, oh, you don't need the urine stuff, much too complicated, do serum. Yeah, and so there's a paper from the Würzburg group and other papers that just came out, a smaller number of tumors. So the Urine Act study, every patient did not only give a 24-hour urine, but was also asked to give a blood sample and a spot urine. So we did this and measured 14 serum steroids and 14 urine steroids. And then it was used to train the algorithm and to test the algorithm. And that actually showed that 24-hour urine is well superior to serum, yeah, and by more than 10%. And we did this also, then condensed this to 8 steroids. And that showed that also 8 steroids urine is superior, and it maintains the same performance as if you use 14 steroids. So 24-hour urine is superior, and this is what we will go for. And so I hope that you stay with me for the last algorithm picture. That is actually how we will do it. You don't need to worry about patients that have a Hounsfield unit less than 10 or are less than 4 centimeters with 10 to 20, because in our study, 0% at ACC. And you don't also, therefore they get no further imaging. Nobody will have ACC unless there's any other reason for this. In the middle group, if you're larger than 40 millimeters, but you're less than 20, or you're less than 40 millimeter, but are higher than Hounsfield unit of 20, we had 0.7% ACC. Yeah, so that's also not worth your while. So we suggest interval imaging at 6 to 12 months. And then basically this is a group we are interested in for the urine test, and they should have urine as the first measure. And if the urine is positive, they should go to surgery. Yeah, and if it's negative, they should have an FDG PET. And if it's positive, they should go to surgery. It will still have lots of false positives, but better than missing one. And if it's negative, people can decide for a biopsy or interval imaging. Yeah, so that's sort of like the accelerated pathway to diagnosis of ACC. And this shows you all the people who were involved and are involved. And James Hawley, who is a Jane Flory Clinical Research Training Fellow here in the MRC LMS part-time, yeah, because we take people from all over the UK, and he does 60% in Manchester and 40% at PhD here. Many thanks.
Thank you very much, Professor Arlt. That was really an excellent talk. Do we have any questions from the room?
Antoine.
Thank you. Excellent talk. I'm happy to have been part of the Urine Act study. I was wondering, do you still need a 24-hour urine collection? Because we know it's a little bit cumbersome. It's subject to error also. Can you do it? Do you have the same performance if you use only a spot urine or morning urine excretion?
Yeah, so we can answer this very soon, Antoine. The question is, can we do spot urine rather than a 24-hour urine? Yeah, the technical, if I treat the 24-hour urine, we did this calculation already like a spot urine. If I express it not at microgram per 24 hours, but as microgram per liter, then it actually has the same performance. But the problem is that a real spot urine is much more dilute. Yeah, so what we just completed is measuring all the spot urines from the Urine Act study, which is about 1,000. Yeah, so we had a randomized list, and we are currently calculating this. So very soon we will be able to tell you if a morning spot urine is sufficient. But what I know that will be definitely sufficient, and which we is something which I totally would do, is to do a timed overnight urine, which the patients actually have no problem with. So a timed overnight urine is much more intelligent. Alessandro Prete and I have a project where we showed this in Cushing's, yeah, because during the day, which will be published soon, during the day, we eat, we stress, we run around, we move, yeah, but in the night, if you go to bed with the intention to sleep, that's what the patients are informed about. So if you go to bed with the intention to sleep, then you should go to the bathroom and pee for a last time into the toilet, and then note on your little sheet you get, I went to bed at 22:37 or so. And then in the morning when you get up, you pee into the pot, yeah, and you write, I got up at 6:15. And if you go in the night, you also pee into the pot. And then we calculate the excretion microgram per hour. Super convenient for the patient because they just need the pot in the bathroom overnight, yeah. And I'm absolutely certain from the preliminary results that will be better than a spot urine, yeah. And but it's very convenient for the patients to do, and we are working on solutions now with intelligent mass spec solution that the patients get them from their clinical center a sticker sent home and a collection bottle, yeah, and which is pseudonymized already, you know, like sort of, and then they can collect themselves, yeah, instructed by a nurse if needed, and then turn it around 3 times and then aliquot and send it in a padded envelope to the lab. Yeah, so that the patient even doesn't have to come in to drop it off. Yeah.
Thanks, Yvka. I was going to ask, we're seeing more and more ACCs being picked up incidentally, and of course they don't all start at 4 centimeters. So for lesions that are smaller, like 2 or 3 centimeters with unenhanced density of over 20, do you think there's a role for USP there in terms of ruling in or ruling out ACC?
Yeah, the problem is, so obviously you saw our nice size distribution, which was very spread and had not many people, let's say like, not many people that were under 4 centimeters, I think 3 of the 100 patients. And I talked to John Deeks about this, and he said that statistically proves, because it's a non-biased prospectively collected cohort, that in general, 99% of the ACCs will grow very quickly. Yeah, because otherwise, he said, you would statistically expect a completely different distribution. Yeah, and if you have boom, yeah, so an exponential curve, that means this tumor is growing fast. So that means we all see in large centers, we all see small tumors. Yeah, and they will be picked up. This has a high sensitivity, but the problem is always, will there be false positives, and what are the consequences of this? So we will do we will map down, so we currently think that possibly the cutoff can lie at 3.8. But after that, you get a large number of benign tumors, and it's not worthwhile to do all this testing for like messing one in a blue moon or something. Yeah. So the cutoffs were actually underpinned by a modified Delphi consensus. Yeah, so we asked, I think 21 clinicians, I think Antoine was also part of that, yeah, like to say, how sure do you want to be about a diagnosis of ACC? How many are you willing to miss, and so on? Yeah, all these questions were asked, and then John and Alice worked up how this impacts on the cutoff that are set, so that this is achieved, what the clinicians want.
Hi, thank you very much for that talk, it was great. I wouldn't say I've read all your papers, but I've read a lot of them. In my experience, in my center of urine stereoprofiling, we do often see ACCs that don't show the classical markers. So they don't show metabolites of 11-deoxycortisol, DHA, 17-hydroxypregnenolone. So is there a bit of a concern that moving to a specific targeted LCMS panel that you might miss an ACC?
I wouldn't have this concern because we obviously base it on a large number of patients. Yeah, like sort of, if you have like 100 or 200 with ACC, yeah, like for example, for the subclustering, we have used, I think, 152 patients with ACC that are well characterized, then I don't think you miss something that would then come along around the corner. Yeah, like sort of, or there are different people, not all have all the markers high, but they have a combination of them high. And also, we did several studies of that. The computer overspeeds the woman. Yeah, there are profiles where I say, oh yeah, I think risk of ACC, because the computer looks at how the different steroids relate to each other. Yeah, and not like what is the absolute value or, like sort of, so then it is a pattern detection which the human brain cannot do as good. Obviously, experienced biochemists can detect a lot of pattern, yeah, like sort of this, how Cedric Shackleton, he doesn't taste them, but he just looks at them. Well, that's such and such disorder, steroidogenic inborn disorder, yeah, like sort of, but the computer is always superior. They have 2 published studies there that showed this. It's nice to be a good expert, but the computer beats you. It doesn't mean that the
That's a shame.
tell the computer what to do and what you want from the computer.
Thank you very much.
Just following on from that before that's probably the last question. So just thinking about the disease heterogeneity in ACC and the fingerprint, and are you getting any insights around that? Just thinking about the cluster analyses of ACC and the worst prognostic one being CPS,
There's a book that has worst prognosis, yeah, like I don't want to take the thunder away from the thunder away from, thanks so much, from Vasilis, but there is one that has a worse prognosis and has different Ki-67, different histology markers and so on.
So I was just wondering on the urine, has it going sort of a deep
Yes,
dive
but
of the
for this we need more data. Yeah, so like one of the advantage of the machine learning is also that you can improve the algorithm. Yeah, both its sensitivity and specificity by feeding it more cases that are confirmed. Yeah, and that means from time to time you can update the algorithm and then it becomes better. Yeah, Vasilis, when he was still a PhD student, did a study with me where he looked at also recurrence detection and is highly sensitive in detecting recurrence. Yeah. So, and it's completely non-invasive. So it's something that patients can do frequently. Yeah. So it picks things usually 2 to 3 months ahead of imaging. Yeah. So it could also trigger imaging that then you run a PET CT and see what has come back. Because as we all know, in the management of ACC, it's really important to know quickly if there's a recurrence so that we can see, can we address it surgically? Can we address it anywhere else?
Yeah, I think we've got a last question.
I'm just going to expatiate on the heterogeneity of the tumor or the lesion on the CT. So the over 20 Hounsfield, is it a cumulative number, or if it is the highest Hounsfield score within the heterogeneity of
it's like you usually, yeah, obviously one has to follow the guidelines and then say if the tumor is heterogeneous, then if there's heterogeneity in the tumor, we treat it as if it would be above 20 Hounsfield units. Yeah, but we do not quantify. Yeah. So like, but obviously depends a little bit. Sometimes you have tumors that fulfill the criteria, but have large areas of fat. Then you think already it's like a partially lipid poor adrenomyelolipoma. Yeah, but either if it's heterogeneous, we treat it as if it would be higher than 20 Hounsfield units. But the important message is also 10 to 20, nobody cares for. Yeah, like this is the algorithm. Yeah.
So heterogeneity
Is a suspicious criterion.
There's much more currency.
Not much more, but is equal to greater 20 Hounsfield units. Yeah. Usually the radiologist will not quantify if it's heterogeneous. They will not give you a Hounsfield unit number.
We've actually got 2 competing questions. I feel like we could, if we take this one, I feel like we have to take Tom's as well.
Okay, I will be fast.
Thank you. Wonderful speech. Just wondering, in MET, if it's like METs from lung cancer or something like that, do they have a completely different profile? Do they secrete anything at all?
Yeah, they are negative. This is why in my flow chart, and because they have no adrenal cells and so on, and this is why in my flow chart I say if you are negative and it looks very suspicious, then you might also consider this MDT decision to do a biopsy, because if you in this group that is in the intermediate group, yeah. So we have I simplified it a little bit. We have low risk, we have intermediate risk, which is very low risk still, and high risk. And if you fall into this intermediate group, we give a score of 0 for no risk, 1 for intermediate risk, and 2 for high risk. Then it is worthwhile to do a biopsy, because there is a large percentage of other benign and other malignant tumors that you can actually diagnose by biopsy. Yeah. Well, obviously upfront you would never do that. Yeah.
It's a quick question. Do you think that the liquid biopsy could be a potential competitor?
Liquid biopsy to
like free DNA, so whatever form.
Well, now I have to be careful, because obviously I collaborated with Christina Ronke when she did her liquid biopsy study. Yeah, so I think it is interesting. Yeah, like sort of, it is obviously much more involved and much more expensive. Yeah, so like, so one has to see how this goes, but obviously it might be an additional security thing, I think, in recurrence monitoring. Yeah, so in our very limited series, urine did better, but you know, that has to be examined in a large prospective study. Yeah.
Vibeke, thank you for a tour de force that we will all no doubt talk about more over lunch. Thank you. I'd like to introduce Ruth. I'm sure many of you will know Dr. Ruth Casey, who's clinical lead for neuroendocrine tumours and endocrine oncology at Addenbrooke's and the University of Cambridge Hospitals Trust, and has research interests in translational research, and is the PI for the SFE adrenal tumour study.
Yep, thank you very much. Thanks very much for the introduction, and thank you to the organisers for inviting me to speak. I have, unfortunately, the difficult task of following on from Professor Arlt, but I'll do my best. So I'm going to discuss actually both 18F-CETO, but also 11-C-metomidate to some extent, and its role in adrenocortical carcinoma. So just by means of a very quick background, I don't think I need to tell this audience, will be aware that adrenocortical carcinoma is a rare but devastating diagnosis. We expect to see about 1 to 2 patients per million of the population per year affected by adrenocortical carcinoma, more common in women than men. Survival rates have improved over the last 5 years, but for patients presenting with stage 4 disease, prognosis or overall survival is still very poor. About 2/3 of patients will have evidence of an endocrine syndrome, with Cushing's being the most common. And again, this is more commonly seen in women than men. And increasingly, ACC is being detected incidentally, as we've just heard, in cross-sectional imaging, and some studies reporting up to 40% of cases detected incidentally on CTs performed for another reason. So most people will also be familiar with the European Network for the Study of Adrenal Tumour staging system for adrenocortical carcinomas. So just to remind everybody, stage 1 is a localized tumour less than 5 centimetres. Stage 2 is a localized tumour greater than 5 centimetres. Stage 3 is a locally invasive tumour of any size. And stage 4 is obviously tumour with distant metastases. And we know that the stage of the ACC at diagnosis is a very good predictor of the overall survival or outcome for our patients. And for those patients who present with localized tumours, we know that getting a clear or zero resection is also a very good predictor of tumour-free recurrence. But aside from that, there are a number of other prognostic indicators that are coming forward, including Ki-67, for example. So we know that a Ki-67 of greater than 30% is likely to confer a worse prognosis for patients, whereas a Ki-67 of less than 10%, we saw from the Indivo study, is associated with a better outcome and a lower risk of tumour recurrence for our patients. Other potential prognostic indicators, well, there is mixed debate in the literature about whether autonomous cortisol secretion is associated with a worse outcome. I think the overall feeling is that it's not giving us information about the underlying tumour biology per se, but rather patients who do have Cushing's syndrome are likely to have severe metabolic complications, which are likely to delay the onset of their oncological treatments or perhaps result in potential pauses in their oncological treatment over the course. And of course, patient age and fitness is also going to be a predictor of how well patients do. But if we look at the kind of new understanding of risk stratification for ACC, as I mentioned, low risk will be these patients who have NSAT stage 1 or 2 and a Ki-67 of less than 10%. And this is in the context of patients, who've had curative surgery or surgery with curative intent of a primary ACC. The standard risk are patients who have NSAT stage 1, 2, or 3, but a Ki-67 of less than 30%. And then the very high risk patients are, of course, patients who have stage 4 disease, who have had incomplete resection, so R1 resection, or Ki-67 of greater than 30%. But we have heard already a little bit this morning about the degree of heterogeneity for some patients with adrenocortical carcinoma in terms of predicting outcomes. And I think probably the cohort where we see the biggest amount of heterogeneity is in this standard risk cohort. And I think in this cohort of patients, there is a definite unmet need for better or additional prognostic markers. So this brings me nicely onto the role of adrenocortical specific imaging tracers. This morning, we've heard a lot about adrenocortical specific imaging tracers, including those that bind specifically to CYP11B2, but then also those that bind to both CYP11B1 and CYP11B2. So these are 11-C-metomidate and 18F-CETO. which has now largely replaced 11-C-metomidate in clinical practice, as we heard this morning, both because it has a longer half-life, but also gives us superior imaging resolution. We've heard this morning how 18F-CETO has predominantly been used in clinical practice in the context of primary hyperaldosteronism as an alternative to AVS to identify the secretory nodule, to allow us to target surgery appropriately, and more recently to identify nodules which may be suitable for thermal ablation. But in Cambridge for some time, we've been considering whether using 18F-CETO or 11-C-metomidate that bind to both CYP11B1 and CYP11B2 may allow us to, if you like, characterize or analyze a broader spectrum of adrenocortical disease in clinical practice. And one of the first hypotheses, if you like, that we had was whether we might be able to combine 18-FTG PET-CT and these adrenocortical specific tracers, so 18F-CETO and 11-C-metomidate, to better characterize an indeterminate adrenal mass. Well, what do I mean about an indeterminate adrenal mass? These are adrenal masses that cannot be radiologically characterized as benign lipo-rich adenomas, as we've just heard. So these would be adrenal masses that are either large, greater than 4 centimeters, and that typically have, that are heterogeneous or have an unenhanced density of greater than 20 Hounsfield units. And how might combining these two tracers help us? Well, one will tell us whether the adrenal mass is adrenocortical in origin or not. That will be if we use 18F-CETO or 11-C-metomidate. And one will tell us about the metabolic activity of the adrenal mass and help determine whether it's likely to be malignant or not. So let's just look at some examples of this hypothesis. So for example, we'd expect an ACC to be metabolically active, so have high uptake on 18-fluorodeoxyglucose PET-CT, and also to have high uptake on either 18F-CETO or 11-C-metomidate. An adrenocortical adenoma, for example, a lipid-poor adenoma, would be expected most of the time to have low metabolic activity on fluorodeoxyglucose PET-CT and have high uptake on either 18F-CETO or 11-C-metomidate. What about a non-adrenocortical tumor? So for example, metastases, well, of course, this will have no uptake on either 18F-CETO or 11-C-metomidate, but will be metabolically active on fluorodeoxyglucose PET-CT. And finally, what about a mass that is large, say greater than 4 centimeters, heterogeneous, but has no uptake on either FTG PET-CT or CETO or metomidate? Well, this is likely to be a non-adrenocortical benign tumor, for example, a ganglioneuroma. How has this played out in clinical practice or in our studies? Well, I should acknowledge both Russell Selinaki, I don't know if he's here, but also James McFarlane. So this study was started by Russell Selinaki and since has been expanded by James McFarlane in Cambridge. And this was using, as I say, a combination of fluorodeoxyglucose PET-CT and initially 11-C-metomidate, but more recently 18F-CETO to characterize these indeterminate adrenal masses. So let's work through two examples. So the first case here, you can see this is a large right-sided adrenal mass. This has high uptake on 11-C-metomidate PET-CT and also on fluorodeoxyglucose PET-CT. And this histologically is proven to be adrenocortical carcinoma. If we look at the second case, this again is a right-sided adrenal mass. This time we see no uptake on 11-C-metomidate, but it is metabolically active. This patient went on to have a biopsy and did have a non-adrenocortical malignancy. This time this was lymphoma. But as we did this study, what we started to note, in particular for the patients who had adrenocortical carcinomas, was that we were seeing a good degree of heterogeneity in terms of the tracer uptake in the adrenal cancer tumors, be that the primary tumor or the metastases. And I'm just going to take you through two examples. So this first case here is a patient who has a very large, as you can see, left-sided adrenal mass. And you can appreciate that there is patchy or heterogeneous uptake of the 11-C-metomidate tracer within the primary tumor. And you might argue, well, okay, the area of photopenia may be just due to hemorrhage or necrosis, but actually there was no correlate in CT to account for this photopenia. And you can see that the concurrent fluorodeoxyglucose PET-CT over here shows a much more homogeneous uptake. The second case, similarly, this time again, right-sided adrenal mass. Again, you can see very patchy uptake of 11-C-metomidate, this central area of photopenia. And again, on a concurrent fluorodeoxyglucose PET-CT, we see even a different distribution of uptake of the FTG PET-CT. So this made us consider whether what we're seeing is intratumoral intratumoral within a primary tumor, for example, or even intratumoral within the same individual, heterogeneity of CYP11B1 expression. We're capturing this in vivo, if you like, and whether this could be telling us or giving us information about the potential biology of the adrenocortical carcinoma. And so to take this forward, James McFarland worked with one of our pathologists in Cambridge, John Tadros, and looked at 46 adrenal cancer specimens. We only included patients that were NSAC stage 2 or 3 with or0 resection to try and reduce the heterogeneity of the analysis. And what James did was look at CYP11B1 expression using semi-quantitative immunohistochemistry. And what he saw was that there was huge variation across in this cohort in terms of CYP11B1 expression. And initial analysis suggested that this reduced CYP11B1 expression correlated with poorer outcomes in this patient population. So the next step for us in Cambridge was to try and further explore this finding in a larger cohort of patients, ideally patients who'd also had imaging either using 18F-C2 or 11-C-metomidate. So we collaborated with colleagues in Uppsala. So this was Joachim Krone, Anders Sundin, and also their excellent fellows in Uppsala, Adam Edholm and Liang Zhang. And we were able to pull together 90 patients with adrenocortical carcinoma that had had imaging with 18F-C2 or 11-C-metomidate. And these were divided into 2 cohorts. The discovery cohort, if you like, were 20 patients who had had concurrent 18F-C2 and fluorodeoxyglucose PET-CT, and then a further validation cohort of 70 patients who had either had 18F-C2 or 11-C-metomidate, but had not had concurrent fluorodeoxyglucose PET-CT. And so let's look at some of the results. So I'm going to predominantly focus on the discovery cohort, so the 20 patients who had had concurrent CTO and FTG PET-CT. And just to orientate you to the methodology, what we did was that in each respective center, the fellows leading on this sat with experienced nuclear medicine physicians and analyzed both the fluorodeoxyglucose PET-CT and 18F-CTO. And for patients with metastatic disease, the tumors were compartmentalized to the various organs. So for example, lung, liver, and bone, up to a maximum of 20 lesions at each site. And then the lesions were dichotomized as either having positive or having high or low uptake on both CTO and FTG. And for reference for CTO, we used the bone marrow signal and the L4 vertebra. And for the FTG PET, we used the liver for reference. So then just to orientate you to this grid, so I can show you the next images. We had 20 patients and 235 lesions. So in yellow are patients who had high CTO uptake but low FTG. Green is where the lesions were high in both CTO and FTG, and black is where the lesion was high on FTG but not on CTO. And I'm just going to show you some cases because there was huge variation. So patient 3, as you can see, is a patient who had multiple lesions, multiple metastatic lesions in a patient with confirmed adrenocortical carcinoma, which had high uptake on 18F-CTO, as you can see, and many more lesions were detected on 18F-CTO than on fluorodeoxyglucose PET-CT. But then we had other patients like patient 20, where none of the metastases had high uptake in 18F-CTO, and the lesions were positive on fluorodeoxyglucose PET-CT. So in both the analysis from the discovery cohort and later the validation cohort, what became apparent was that 18F-CTO is very sensitive for the initial diagnosis and staging of treatment-naive patients with adrenocortical carcinoma. It also became apparent that mitotane, as you might expect, significantly affects the sensitivity of 18F-CTO and 11-C-metomidate, and the imaging in these patients was correlated in a small number of patients with RNA expression of CYP11B1, which was reduced in the patients who had low uptake on 18F-CTO or 11-C-metomidate. And what also became clear was that we were seeing 3 distinct imaging phenotypes in these patients with adrenocortical carcinoma. The first was patients who had homogeneously low CTO uptake. So these are patients with metastases or tumors where we saw, predominantly patients with metastases where we saw no CTO uptake in any of the lesions. And importantly, within this group, almost all of the patients had been pre-treated with mitotane. The second imaging phenotype were patients who had a high CTO uptake. So all lesions were positive on 18F-CTO. This would be similar to patient 3 here. And then we had a third category of patients where the imaging phenotype was characterized or classified as heterogeneous. So these were patients where some of the lesions had high uptake on 18F-CTO, but other lesions did not have uptake on 18F-CTO. This table here is just to show you some of the differences in terms of the clinical findings, if you like, of the three imaging phenotype cohorts. So the high C2 uptake, the low C2 uptake, and the heterogeneous imaging phenotype. The main difference was that the main differences are highlighted in yellow at the bottom, in that the overall survival was much shorter in the patients with the heterogeneous imaging phenotype. But you will note that most of these patients had either stage 3 or 4 disease at presentation in the heterogeneous imaging phenotype, and none of those patients had been treated with mycetane, whereas almost all of the patients in this column here who had the homogeneously low C2 uptake had been treated with mycetane. The other difference between these cohorts was that patients in the heterogeneous imaging phenotype also had a higher Ki-67 with a median Ki-67 of 30% in this cohort. But what we wanted to do, although numbers were small, was to try and determine if there was any prognostic impact that we could ascertain from these imaging phenotypes. And what we did is we looked at overall survival from the time of diagnosis across the three imaging phenotypes. And we saw that those patients who had a heterogeneous imaging phenotype had a much shorter overall survival or poor overall survival. I should also mention that in this analysis, we excluded all patients with NSAID stage 1 and 2 disease. And we also then went on to look at progression-free survival from the start of systemic therapy, noting that in this, across this whole cohort of patients, there were some who'd had mycetane treatment before they received imaging. But when we looked at progression-free survival from the start of systemic therapy, we still saw that patients in the heterogeneous imaging phenotype had a shorter progression-free survival. This is just an anecdotal example from one of our patients in the Cambridge cohort. So this is a 39-year-old patient who presented with stage 4 adrenocortical carcinoma. In the first column is his 18F-CTO at baseline at presentation, and then a CT at 8 and 16 weeks into systemic treatment with chemotherapy for his stage 4 ACC. And what I wanted to just initially highlight was that there was heterogeneous uptake within the primary ACC. And in fact, he also had lung metastases, which had no uptake of 18F-CTO at all. And as this patient progressed through his chemotherapy and had surveillance scans, what we saw was quite rapid, accelerated growth of the lung nodules and of the disease that wasn't 18F-CTO avid. And though these tumors progressed at a more rapid rate than some of the disease that was 18F-CTO avid. This is obviously a single case. So following on from this study, which we have just submitted for publication, what do we think the role is for 18F-CTO PET-CT in patients with adrenocortical carcinoma? Well, this was the largest study published to date, but I have to acknowledge there are a number of limitations. Patients were both retrospectively included in the study and prospectively acquired. Patients included in the study represent the entire spectrum of ACC diagnosis. There was patients who'd just been diagnosed with a primary tumor and patients who had metastatic disease that had had several lines of treatment before they had imaging with either 18F-CTO or 11C metomidate. So of course, any of our findings will need to be validated in prospective studies, but we do think that there is a role for 18F-CTO to study ACC biology in vivo, and particularly how that biology is potentially shaped by both time and treatment. So I think, as I say, there is a need for prospective multi-center studies using longitudinal 18F-CTO plus or minus 18F-GG PET-CT to see if we can better stratify prognosis for these patients using these PET tracers. It will also be very helpful for us to better understand the effect that mycetane has on the sensitivity of 18F-CTO. Is it a duration effect? Is it a concentration effect? Does it vary from patient to patient? I think it will be incredibly important to overlay these imaging patterns with other omics like urine steroid metabolomics, transcriptomics, and genomics from tumor biopsies. And I think it will be very interesting to include these imaging tracers, so 18F-CTO, for example, in an exploratory arm in clinical trials, such as, for example, the ADEVO-2, as we may gain further prognostic insights. So I'm going to finish there, acknowledge my colleagues, Mark Cornell and James McFarlane from Cambridge, and our collaborators in Uppsala listed here, and hopefully have time for 1 or 2 questions.
Bruce, fantastic. This is a lot of work. Yeah, I know this because I was involved for many years with Steffi Hahner and her study that was published last year, which was for differentiating using IMTO FTG PET, so a very similar approach.
Yeah.
And so what she also obviously found is that it is very heterogeneous. Yeah. And so we did actually urine steroid metabolomics for this study. So the results will be published soon together with some tissue metabolomics. But I think it's very interesting, the aspect that you found on the prognostic side. Yeah. And I think the key thing is really to do more experimental medicine approaches to understand what is the biologic difference between them. And also, you know, like get more prospective and non-metastasized. Yeah, it's a big effort, but I think, you know, that's a great approach for a networking study.
Yeah, so that's exactly what we want to do, because the problem was in this cohort was incredibly heterogeneous. As I said, there were some patients that had received myostatin for many years and had other lines of therapy, and we don't know what impact that is having on the sensitivity of these tracers. But and the other thing is we had about 20 patients in the entire cohort where we had tissue samples on them. I think the ideal situation would be that we have tissue on everybody.
Yes, yeah, like so, but it takes a long time and needs a lot of organization. So it was extremely painful for Steffi to arrive as a 85 with all the biomarkers and so on. Yeah. Well done.
Ruth, I have a question about the heterogeneity of the MTO or CETO. I mean, it just happened that the Ki-67 is very high in heterogeneous. So I just wonder whether that heterogeneity is actually the necrosis. You know, there are big tumors. They outgrow the vascular supply. You end up, rather than different metabolic activity, you just ended up with tumor which partially necrosed.
Yeah, so that's what we initially thought, Tom, but when we talked about the heterogeneous imaging phenotype, it wasn't necessarily just heterogeneity within a primary tumor. It was patients, for example, with metastatic disease, where some of the tumors would have uptake and others wouldn't. I think, yes, it was an observation that the Ki-67 of the primary tumor, which was the tissue that we typically had the biopsy from in these patients, was higher than in the other groups. But I think that's reflective of the fact that this cohort of patients are biologically behaving more aggressively, and that the CETO is just giving us that information as well. You see what I mean?
Do you know anything about the genetic background, as in P53 or Wnt1 overexpression or anything like sort of targeted before the RNA-seq?
Yeah, so I think there was very small numbers that had RNA sequencing analysis in this study. We had 20 tumors, and unfortunately, many of those were patients who had myostatin therapy. But many of the patients who had the heterogeneous or the low CETO uptake were patients that were classified based on RNA-seq as being as having a less mature adrenocortical differentiation score. But we think that might also be driven by the myostatin treatment. So that's why what we really want to do is have tissue up front in treatment-naive patients, and perhaps repeat it at intervals. So I think we don't have an answer to that question based on this data.
There's a quick question about mitotain. So mitotain seems to, I thought it was adrenolitics, but it's adrenolitics and there's no uptake on your scan, but on the FDG, they're still there.
Yeah, so on the FDG,
they're still growing.
They're still positive, yes. But not every single patient who'd been pre-treated with myostatin had low uptake on CETO, but the majority did.
Yeah, I think like on the steroidogenesis side, it's like it's a general downregulation of steroidogenesis. Yeah, it's not a specific CYP11B1 inhibition, but it's just like steroidogenesis downregulated in total. Yeah, and therefore there will be less uptake. Yeah.
Any other questions? In that case, just remains to say thank you very much for coming all the way from Cambridge.
Very much. We've got Dr. Mark Quinn from King's College, who is a consultant and is going to tell us about combining bulk and single cell RNA-seq in pheochromocytoma. Thank you so much.
Thanks, guys. So hi, everyone. My name is Mark Quinn. I am a consultant endocrinologist in King's College Hospital. And today I'm going to talk about the work that has been the basis of my PhD, which is still ongoing over the last few years in collaboration with GSDT and with King's College London. I'm going to talk about some transcriptomic approaches to identifying potential markers of aggressive disease in both pheos and paragangliomas. So everybody in the room will know most of this, but PPGLs are neuroendocrine tumors, essentially of the autonomic nervous system, and they can arise anywhere from the base of the skull to the pelvis where these cells exist. They predominantly follow a benign course. So in about 80% of cases, a PPGL will arise, it will be resected, and hopefully that'll be the end of the story. But in about 20% of cases, They follow a metastatic or aggressive clinical course. And in those patients, treatment options are very limited and the 5-year survival is poor. PPGLs are one of the most inherited of all tumor subtypes. So we now know about 40% of PPGLs arise in the presence of one of these pathogenic germline variants or mutations. And this is the panel that we now offer for all patients who present with a PPGL within the NHS. And I'm going to talk about mutations or variants affecting the mitochondrial enzyme succinate dehydrogenase in the main, mainly because they are the most common, but also they demonstrate a variable clinical phenotype that is not yet fully understood. So succinate dehydrogenase is a 4 subunit a transmembrane protein or enzyme that lives in the inner mitochondrial membrane. It has a role in mitochondrial energy production, essentially, more specifically with it converts succinate to fumarate within the Krebs cycle. We don't know why, but we don't fully know why, but when there are defects in any one of these subunits, that leads to the development of PPGLs. And again, most people will know this, that if you have a defect in SDHD, you are more likely to develop a head and neck tumor that is non-secretory and it rarely metastasizes. But if you have a defect in SDHB, you are more likely to develop a paraganglioma of the abdomen, and that is more likely to be secretory and more likely to metastasize. And we don't fully understand why there is this clinical difference. Additionally, SDHD variants, or patients who carry SDHD variants, display this parent of origin effect, whereby if you inherit it from your father, you are likely to develop disease, or you're at risk of developing disease, but if you inherit it from your mother, you are not. And that's not fully understood. SDHA variants carry a very low penetrance of less than 5%. Those are very rare, as are SDHC variants. I spoke about the difference in metastatic risk. So there are some reports that say SDHB variants carry a metastatic risk of up to 40%. That's likely an overestimation. And then even within SDHD variants, there are these truncating variants that tend to behave more like an SDHB in terms of metastatic risk. A lot of these questions are unanswered or partially answered. I'm going to talk about this, the difference in metastatic risk, for the purpose of today's talk. And we think that some of the answers to these questions lie in the epigenetics of these tumors. And epigenetics is the kind of toolkit that a cell has to make DNA accessible or inaccessible. So we all have the same DNA in every cell in our body, but what gene is then transcribed is dependent on the various different epigenetic changes. So DNA methylation is an important one in PPGLs. This is the addition of a methyl group to a certain segment of DNA that allows for it to be closed over and therefore inaccessible. And this, a very similar slide was presented earlier, and we heard a lot about metabolomics, but the kind of medical school understanding of molecular biology, DNA becomes RNA, becomes a protein, becomes a metabolite, and that dictates the phenotypic expression of a given cell. The study of each of these is huge, and we lie in between genomics and transcriptomics, really, in epigenetics. Why is this relevant for PPGLs? Well, in 2017, the Cancer Genome Atlas was published by Lauren Fishbein and her team that looked at 179 PPGLs. So they took 179 PPGLs and they asked, what genes do these tumors express? And when they looked at them, they found that they could be grouped together in clusters. And that's why we now know of PPGLs in clusters, cluster 1, 2, and 3, pseudohypoxic kinase signaling and Wnt altered. And those are just titles, but the reason that they're grouped together like that is their transcriptomic signature, and that relates to their genomic signature. So I've highlighted the SDHBs and Ds, those obviously grouped together. Separately, they performed a methylation analysis on the right there, and you could see that SDHX or cluster 1A PPGLs were hypermethylated when compared to other PPGLs. And that's unusual in cancer. Most cancers are hypomethylated. So that implies that there is gene silencing going on in cluster 1A PPGLs that is not going on in other PPGLs. So that's the kind of molecular biology background, or kind of basis. I'm going to talk about a clinical case now that highlights the clinical question. So this is a 47-year-old patient that attended between GSDT and King's. She was found to have an SDHB pathogenic variant via cascade screening. So her nephew was the index case. She was asymptomatic. She had an MRI that showed a mediastinal lesion. This was resected and found to have a low proliferation index. She did well after the operation. Postoperative imaging was fine. Urinary catecholamines normalized, and she was discharged to a local hospital where she was plugged in for a screening protocol that all these patients get now for a full body MRI every 2 to 3 years and clinical review every year. 10 years later, she presented with a fractured neck of femur. This was found to be a pathological fracture from a metastatic deposit of a PGL. She had a scan that showed recurrence of disease, widespread metastatic disease, and she eventually underwent a spinal surgery for impending spinal cord compression because of a bony met in her spine. And this showed dedifferentiated disease with a Ki-67 index of 25%. She had lutetium and she had a number of complications and she died in 2021. And I point this case out because it nicely demonstrates this kind of dichotomy within PPGLs where you have this incredibly benign appearing course at presentation, followed by a rip-roaringly aggressive course after recurrence and metastatic disease. Also, there's this 10-year window of apparent complete remission. And this lady had her screening, she had her MRI scans, everything was clear, and she just represented with this incidental metastatic disease. And that's not that uncommon in PPGLs, whereby you have this period of remission. So if I mentioned that 20% of PPGLs go on to develop metastatic disease, half of those will be metastatic at diagnosis, and the other half will present with metastatic disease at a mean time of 6.5 years. So this lady was 10 years. There are cases reported of up to 30, 35 years, but the average duration is about 6.5 years. So that's why it's important to keep an eye on these patients, keep monitoring them, and plug them into the screening protocol. So our question is, well, in the same way that the TCGA looked at the expression profile of all PPGLs, what if we chose a selection of metastatic PPGLs and compared them to non-metastatic PPGLs? Can we find any genes that might be implicated in the development of metastatic disease? And then separately, we want to use single cell RNA sequencing that I'll talk about shortly to interrogate what role those genes might have in the development of metastatic disease. So this is essentially a differentially expressed gene analysis. And this is where we get a number of primary tumors that are found to be non-metastatic and compare them to a number of tumors that are found to be metastatic. And the numbers we have are 258 primary tumors versus 95 metastatic primary tumors. And this is a combination of our own work in the lab and publicly available data sets that we can incorporate in together. This gave us an expression profile of each different groups, and then we performed this differentially expressed gene analysis to ask the question, what are the genes that are different between these two groups? And when you do this, you get lots of genes. That's always the case. And then it's about trying to find genes that actually make sense. And there are a number of genes that we've decided to investigate further. But the one I'm going to talk about today is this gene MMP9. MMP9 is matrix metalloproteinase 9. It's involved in normal processes and generally is ordinarily expressed in immune cells. But it has been found to be highly expressed in many cancers in a similar fashion in like breast cancer, pancreatic cancer, etc., without a specific role elucidated. When it's expressed in neutrophils, however, it has a unique role, or it has a perceived unique role in cancer. So this is MMP9's role in neutrophils. Essentially, it's pro-angiogenic. So it allows neutrophils to do its job, to grow blood vessels around it so that it can spread and get to its target, I guess, through blood vessels. And it does this by the loss of its natural inhibitor, TIMP1. So tissue inhibitor of metalloproteinase 1, when it's lost in neutrophils, it allows neutrophils or MMP9 to become active and be pro-angiogenic. Neutrophils are normally, or that's not a panacea, but normally TIMP1 free. But when they're expressed from tumor-associated neutrophils, it has a suspected role in metastatic spread. So that's a little background on the gene. Single cell RNA sequencing, and a lot of people will probably be familiar with what single cell RNA sequencing is, but I spoke about what bulk sequencing is, which is the analogy that's often used is this: you're drinking a fruit smoothie. That is bulk sequencing. So you're drinking it, but you don't know what fruits have made up the smoothie. Whereas single cell RNA sequencing is kind of like a bowl of fruits. You know exactly how many strawberries, how many raspberries, whatever are in that. And that's demonstrated in a graph that's called a UMAP. And that'll show you exactly what the cellular makeup is of a tumor rather than telling you what the expression profile is of the tumor. And then one of the benefits of single cell is that you can interrogate each different cellular population for what genes that population expresses. But it's complex. PPGL, single cell RNA sequencing is not straightforward. You have to collect fresh tissue from the operating theater. So I go to the operating theater, I pick up the tumor, I bring it to the lab, I immediately dissociate it into a single cell solution, and then I hand it off to the genomics core facility, and they pass it through this system whereby each cell is individually barcoded and then sequenced separately. So that is then sent to a sequencer. And then there's downstream analysis that produces a UMAP that looks like this. So these are the 4 samples that we've done, and there's a little history of each case on the top right. We've done 6 to date, but 2 are still in the lab. And essentially what this shows is that these tumors, PPGLs, fairly ubiquitously have a similar cellular population, similar cell groups. I would have expected that it would be mostly chromaffin cells, because these are chromaffin cell tumors. But you can see that it's actually quite a small population of cells in some of the results. So cutting to the chase about our genes of interest, looking at MMP9 expression, we're trying to find a story that might make sense for why MMP9 might be associated with metastatic or aggressive disease. And one thing that kept coming up was that in this sample, which is a SDHB-related paraganglioma, an abdominal paraganglioma in a young woman whose father died of metastatic PPGL, so is likely to have a more aggressive phenotype, we found that her MMP9 expression was isolated to the neutrophils, which is not totally unexpected because it's in this PHEO as well. It's in this paraganglioma too, and it could sort of say it's in the neutrophils of this paraganglioma as well. But the real question was about if it was TIMP1 free or not. And you can't convince me this one's TIMP1 free. This definitely isn't. This definitely isn't, but this is. So our hypothesis off the back of this is that TIMP1 free MMP9 expression from tumor-associated neutrophils may have a role in metastatic progression in SDHB-related PPGLs. We'd like to prove this. We're obviously going to need to increase the numbers from an N of 1. But single cell RNA sequencing is tricky. The numbers in the published data sets are small. I think there's one paper that published 5 samples, another that published 9. So we want to increase our numbers. We want to validate this by knocking down our relevant genes using human cell lines, rat cell lines, and possibly organoids, but this is complex in its own right. So that is our ongoing plan. So in summary, SDHX PPGLs display a variable clinical phenotype that is currently unexplained. A biomarker for the development of metastatic disease is urgently needed. We have used single cell and bulk RNA sequencing to yield some interesting hypotheses regarding the development of metastatic disease, and we need to do more work to clarify the role of MMP9 and TIMP1 in this process. These are my acknowledgements, and thank you very much.
Thank you very much. Really exciting talk. Do we have any questions from the room? I was going to ask you a little bit about just mitochondria, and given that you've done single cell, so any thoughts around sort of metabolic features? I know you've gone sort of down the progression and sort of MMPs, but any thoughts around sort of the metabolic signatures or anything there that's coming out from your data?
From single cell RNA
sequencing? Your metastatic, non-metastatic group. I know you've got the subpopulations for anything around expression of mitochondrial markers, metabolic function, things that might be driving.
Yeah, I mean, we haven't looked at that specifically. Yeah. It's a good question. But yeah, we've been focused on trying to find transcriptomic markers of aggressive disease. But no, we haven't looked at that one. So
I guess within your data set, probably.
Yeah.
Some lipid markers or things that might be driving. Sort of
not really, no.
Okay.
Bruce?
I know it's really difficult to do any work in these fields. It's so rare.
It would be really helpful to look at, because we know that there isn't any huge genotype phenotype correlation for the SDHB genes, and there's been huge work ongoing, as you know, in Europe, looking at this. But we do know that within families, if we see penetrance or more aggressive disease, then we see that more commonly in other family members as well. So it would be really interesting to look at patients within kindreds who've had tumors, including those that have had potentially more benign courses and those that have had more aggressive courses. And I think that might yield some really interesting results. And if you did do that, overlay some serum metabolomics, because I think looking at the succinate would be really valuable in these patients, because we now know that even the heterozygous carriers have elevated succinate, which doesn't make sense. And we know that succinate can also influence neutrophil function, immune function. So it would be really interesting to perhaps overlay metabolomics in those.
Yeah, so
cohorts.
One of the partially answered questions is that succinate probably dictates a lot of this. Like succinate concentration probably dictates a lot of the changes in gene expression, et cetera, et cetera. So we want to try and look at what are the differences between succinate concentration in different SDHXs, and et cetera, et cetera. But what I've ended up finding is so cell specific. So if we find that succinate concentration is higher in this patient or this sample, how does that actually relate to the neutrophils within? Do you know what I mean? So it's really hard to get it down to the niche of a different cellular population. So what we ideally would like to do is like methylation analysis that is similar to single cell. So what is because succinate may have a role in DNA methylation. So can we correlate succinate concentration to DNA methylation changes at a individual cellular level, if you know what I mean? But yeah, to answer your question about the different family members, we did that with bulk RNA sequencing and we found like confusing answers. So with single cell, it's just as you said, I've got 6 samples over 2 or 3 years, and it's really hard to actually get the kindreds involved. So work in progress, but yeah, thanks.
Thanks, Mark. So if I've understood all of that correctly, the thing that you've identified is to do with the immune response to the tumor, enhancing the metastatic risk of that tumor, and that it's found in the neutrophils. Is that felt to be something that's inherent to that person's immune system and therefore could be detected at the time of original diagnosis? Or do we think that's something that the tumor itself is inducing in the immune cells that are responding to the tumor?
Yeah, good question. So I think it might be that it's related to SDHB and the changes that SDHB then brings about in terms of succinate concentration. So I think that if you get a different defect in a different subunit within SDH, you get a different concentration of succinate, and that different concentration of succinate then has an influence at different cellular populations. So the question of whether or not it's specific to the patient or not, I think it's more specific to the pathology of, mutation, succinate concentration, DNA methylation changes, whatever have you. And I think that if the hypothesis is in any way correct, it might be that these cells might lie in waiting, and that this patient, for example, could be one of these pre-metastatic, if you know what I mean, rather than it dictating aggressive disease at the time. So that would be, I guess, the hope. But yeah, a lot of work to prove it. Great.
Thank you very much.
Thanks.
Fantastic talk. Come on down, Panis. We got your talk.
Yeah.
So our next speaker, Panis Doge, is still a medical student here at Imperial.
Yes.
Well done for giving this talk. He's undertaken this project, I believe, under Florian's supervision. We're looking forward to it. Thank you.
Thank you. Good afternoon, everyone. My name is Panis, and today I'm going to be speaking about the role of ACTH monitoring in optimizing glucocorticoid replacement in adrenocortical cancer. So as we're all aware, adrenocortical carcinoma is a rare malignancy of the adrenal cortex with an incidence between 0.5 to 2 per million. And the cornerstone of treatment is surgical resection, followed by treatment with mitotane, an adrenoleukin drug. And mitotane induces patients into adrenal insufficiency as it destroys the contralateral healthy adrenal gland, and subsequently all patients will require glucocorticoid replacement. Mitotane has effects on steroid metabolism. It's a potent CYP3A4 inducer, which increases steroid clearance, and it also induces increases in corticosteroid binding globulin. So all of this means that patients will require much higher doses of glucocorticoid replacement than patients with other forms of adrenal insufficiency. So most commonly, hydrocortisone is used to replace patients in 3 divided daily doses. But the issues with this are the thrice daily dosing burden and the dose titration being difficult due to a lack of reliable biomarkers in monitoring patients' glucocorticoid status. As many of you may be aware, at Imperial, we replace patients with once daily prednisolone instead of hydrocortisone due to its stable pharmacokinetics, which enable once daily dosing rather than thrice daily. And this avoids the non-physiological peaks in cortisol secretion that you get with hydrocortisone thrice daily. And this better mirrors the endogenous secretion of cortisol. And we monitor this at Imperial with an 8-hour prednisolone level reading by way of an internally developed and UCAS accredited assay that's been validated for clinical use. Another benefit of this once daily dosing is that it seems to stabilize ACTH between 4 to 8 hours following the morning prednisolone dose. And this is demonstrated here with an optimally replaced patient with Addison's disease. So on the x-axis, we have time after prednisolone dose at 2, 4, 6, and 8 hours, with prednisolone in red and ACTH in blue.
And as we have the reference ranges in the shaded boxes, and as we can see, the ACTH remains relatively stable. So here at Imperial, we've extrapolated this concept and applied it to our ACC patients on mitotane, using their ACTH readings to adjust their prednisolone levels, as we know that their prednisolone levels are difficult to interpret due to those mitotane-induced changes in steroid metabolism. So we sought to formally assess this method in a retrospective study of our ACC patients between 2008 and 2025. We identified 25 patients, of whom 6 matched our inclusion criteria of histologically confirmed ACC, who were on mitotane therapy and once daily prednisolone with available ACTH and prednisolone day curves. We collected the relevant demographic and clinical data and assessed ACTH as a reliable marker of glucocorticoid status in this patient cohort. We hypothesized that prednisolone levels obtained from our ACC patients would not be a reliable indicator of glucocorticoid status due to the mitotane-induced changes, and that ACTH may instead be a more informative marker to help guide prednisolone dosing. So we had 6 patients in total, 3 female and 3 male patients, from whom we gathered 30 day curve readings. The mean age at diagnosis was 55.3 years, and the average duration on mitotane was 13.3 months. 3 patients discontinued mitotane due to either remission or a lack of clinical benefit in the context of their disease. And occasionally patients had to take breaks, mainly due to gastrointestinal side effects or infection. Importantly, none of our patients had an adverse adrenal event, indicating that they were adequately replaced when using ACTH-guided dose adjustment. So here we have 3 day curves from a patient to illustrate the concept of using ACTH in order to adjust prednisolone dosing. So in day curve 1 on the left, as before, we have time after prednisolone dose on the x-axis, prednisolone in red and ACTH in blue. So this patient was on mitotane 2 grams once daily and prednisolone 10 milligrams, but their ACTH was well above the normal range, indicating that they were under-replaced, and as such, they had their dose increased. Day curve 2 shows a well-replaced patient who was on mitotane 1 grams 4 times daily, and their ACTH was within a normal range, and so they were advised to continue their current dose. And in the last day curve, we can see that this patient had stopped mitotane at the time, and so their ACTH showed us that they were over-replaced and they were reduced to an 8 milligram dose instead. And prednisolone was often either in or close to the reference range in all 3 day curves, but the ACTH levels gave a much more insightful picture of their true glucocorticoid status. Importantly, we found that ACTH levels did not vary significantly between 4 to 8 hours following the morning prednisolone dose, suggesting that there may be a 4-hour stable window from which ACTH readings could be taken in our patients. And this has practical benefits for both patient and clinician, as it avoids the need for time-consuming day curve measurements. ACTH concentrations at 2 hours did vary significantly from those at later time points, which demonstrates that the greatest suppression occurs in the early post-dose period, with ACTH stabilizing thereafter. And prednisolone measurements did not show a similar stability. To conclude, we found that with prolonged mitotane exposure, prednisolone doses were successfully adjusted to achieve normal 8-hour post-prednisolone ACTH, and a single measurement between 4 to 8 hours could help guide once daily prednisolone replacement in ACC patients on mitotane. I'd like to thank my supervisors who supported me as I conducted this project for my intercalated BSc, and the endocrine and oncology team here at Imperial. Thank you.
Really well done, Panis. That was an excellent talk. Thank you.
Well done. That was very nice indeed. Is there a theoretical problem that ACTH is suppressed in the early stages of treatment of adrenocortical carcinoma so that you can't use it as a monitoring tool?
So at the beginning of treatment,
yeah,
it would be
because of the cortisol excess prior to it, and that the hypothalamus and pituitary are suppressed.
Yeah.
Lauren, do you want to take that question? Do you want to go?
I think that in this context, the patient's going to go on mitotane long enough that
It's a question of time now.
Yeah.
Pass this on.
Yes, maybe I should answer that. When this, no,
I think so.
yeah, so this would be at the later stage when patients were already on mitotain, so it wasn't an issue, I think, because it was much later, not in the immediate postoperative follow-up.
So we have our next speaker, Dr. James Pittaway from BOTS. Thank you so much for giving us a talk. So you're an NIHR clinical lecturer and has done extensive work on ACC and is going to tell us about DLK1 and AGRP. So thank you.
Thank you very much, and thank you for the opportunity. So one of the purposes of my talk today is to introduce to the room, hopefully a lot of centres that see patients with adrenal incidentalomas, adrenal cancer, a study that we're about to start, and looking at this study of 2 proteins in the serum and whether they can be useful as an adjunct in the diagnosis and prognosis of ACC. Now, a disclosure is that I have done a PhD in one of these proteins, and the other one is from another centre that has been studied a lot over there. So there might be a real imbalance when it comes to the question. So this is a proposed study with the universities of Parma and Würzburg, and it's going to be done through NSAT, and it's about to be sort of publicised through NSAT to get some interest Europe-wide. But obviously, we want a large UK involvement as well. So basically, yeah, just reiterating some of that. And the key thing is with 2 of these proteins that we're studying, they're both measured by a simple benchtop ELISA. So this is a sort of technology that can be in any hospital laboratory in many countries. And so there's a potential for a wide rollout across healthcare settings. So the protein that I know most about is DLK1, which is this delta-like non-canonical Notch ligand 1. And it's a transmembrane protein, which has a cleaved ectodomain, and that has an unknown receptor sort of at the moment. It's notch-like, so it's known as an atypical Notch ligand, but it's not entirely clear where it lands and whether it is autocrine, paracrine, endocrine. It's paternally expressed, and like many such proteins, is found in high levels in a lot of tissues in the developing fetus, but is low or absent in most healthy tissues. But then expression appears to be turned on again in many cancers. And one of these cancers is adrenocortical carcinoma. Now, one of the places it's found physiologically is in these clusters of cells in the normal adrenal cortex. And these clusters of cells are importantly distinct from the aldosterone producing cell clusters, and they are relatively low in expression of terminal steroidogenic enzymes. So they're relatively undifferentiated clusters within the normal adrenal cortex. And some initial work, preliminary work was published in 2019, showed there appeared to be much more DLK1 found in adrenal cortical carcinoma than in aldosterone-producing adenomas or normal adrenal glands. And this was backed up with the transcriptomic evidence from the TCGA and GTEx. And so the majority of my PhD was looking into this, which was published early this year, into a much larger cohort of adrenal cortical carcinoma specimens and patients. And also this publication contains some mouse work looking at the role of DLK1 as a novel sort of stem progenitor cell marker in rodents. And this is, these are 2 graphs basically showing the tissue level expression of DLK1, sort of quantified, semi-quantified using H-score, and how the higher levels of DLK1 in the primary tumor specimen was associated with an increased level of recurrence and an increased level of progression. The progression not quite reaching statistical significance, but you can see there's a sort of dose-dependent fanning that was statistically significant for recurrence-free survival. And importantly, when we did some univariate and multivariate analyses, the prognostic value for recurrence and progression was independent from other known prognostic factors. So we know obviously steroid excess, Ki67, etc. So this was independent from that and NSAT stage. And as part of the work done in this, we collected some serum samples in 2 different cohorts. There was a prospective London cohort of all patients undergoing adrenalectomy at our centre, and then some patients that were undergoing adrenalectomy for suspicious adrenal lesions here and at UCLH. And we found that in patients that ended up having a histological diagnosis of ACC, there were significantly higher levels of DLK1 in the serum, which in admittedly a small, cohort to begin with, had quite a good specificity and sensitivity at predicting malignancy within this context. And that in the patients where we were able to get some postoperative serum as well, that the levels dropped, suggesting it was shed from the tumor. Now, this was a separate cohort in Würzburg, which had serum collected for other reasons in patients at sort of random times. And it just showed that there was a sort of higher level of DLK1 serum levels associated with a higher burden of disease. So particularly in patients who had a primary tumor in situ with widespread metastatic disease. So this all, and this is just showing that in the same patients where we have serum and primary tumor, that there's a nice positive correlation between the tissue expression as assessed by H-score and the serum DLK1 levels, which, given that we knew that there is a prognostic implication of the tissue DLK1 levels, suggested that the serum DLK1 levels might indeed have a prognostic implication. So that is the basis for doing a new sort of prospective investigation into DLK1. And I will talk about what we will be asking for at the end while I introduce the protein that I know much less about, which is being studied in Würzburg. So this is a agouti-related peptide, which people might know from sort of obesity and well, that's it really. So this is an orexigenic neuropeptide, which is produced in the hypothalamus, and it's an endogenous antagonist of the melanocortin receptors. And this is a graph, I don't have a pointer, showing that the places use analysis of bulk tissue gene expression. One of the places it's found is the hypothalamus, and then the other place that it's found in high abundance is the adrenal gland. And it's known to be in both the medulla, but also found in the adrenal cortex. And it was sort of stumbled across by accident by the team of Würzburg, who were looking actually at its relationship with Cushing's. And they discovered that the levels ended up being much higher in the patients with Cushing's who had adrenal cortical carcinoma compared to other causes of Cushing's and Cushing's disease, or indeed cortisol-producing adenoma. And so this is from the TCGA data, looking at the expression of AGRP across lots of different cancers. It's very difficult to see because it's such a small graph, but the red dots are from the tumor and the green dots are for the normal, equivalent normal tissue. And clearly, adrenal cancer is far higher than anything else. The other spike over here is actually the pheochromocytoma and paraganglioma, as you would expect, something that's also present in the medulla. And this was echoed looking at a published data set of transcriptome from adrenal cancer versus adrenal cortical adenoma and normal adrenal glands. And so a retrospective analysis was done, and this has recently been published in EJE, which showed that the AGRP levels, as measured in patient plasma, were significantly higher in patients that had ACC versus pheochromocytoma, non-functioning, or EIA, which is the endocrine inactive adenoma, a normal cortisol-producing adenoma, or an aldosterone-producing adenoma. And then within an ACC cohort, there appeared to be a correlation between the presence of ACC and then the burden of disease. So low tumor burden and high tumor burden, as assessed by RECIST criteria, showed that the higher burden of disease had much higher levels. And indeed, there is a prognostic influence of these levels as well, looking again at this sort of retrospective data set where there appeared to be a relationship with higher levels of circulating AGRP and an increased risk of overall and progression-free survival. So the plan is that we would like to start a wider study, both with two arms, really, a retrospective arm, so that given the rarity of the condition, we can start getting some normalization data much sooner on, and then a prospective arm to look at these proteins going forward in an ACC cohort. And basically, because it is now going to be a completely standardized data collection, all data collection in NSAT is going to be completely standardized now. The variables are going to be fixed for every study. It'll all be, so it'll be one data entry per center per patient, but then you get 2 bangs for the same buck. And then obviously if they interrelate, which would be unexpected, then, it might be an even bigger bang. So the proposed study is that for the retrospective side, this is looking to validate the fact that there are higher levels in ACC than other adrenal disease, and to learn a bit more about the index values and disease outcomes. So we're asking for a serum sample, so your standard SST tube, any saved serum. So we're asking for samples at diagnosis or pre-surgery, and then any available follow-up samples. Now, a lot of places across Europe have sort of active ongoing biobanks. They have a lot of these samples kind of ready to go. So that's the kind of plan to get this going. And then obviously the relative clinico-pathological data, which we entered into REDCap, as will all NSAT things. And the plan is to really, as soon as the project goes live, which hopefully should be in the next couple of months or so, we can start collecting. And then the prospective study is we're asking for a little bit more serum at patients who are suspected to have ACC or indeterminate adrenal lesions. We start at the same time, get an index sample at diagnosis, and then we repeat samples at time of routine clinical follow-up 3 monthly for a total of 24 months. And then that will be something that would start now and obviously go forward. And we're aiming to end up with 100-ish ACC patients. There are some more detailed sort of power calculations in the formal proposal that will go around, but I don't have all the numbers off the top of my head at the moment. There is already interest from a couple of places, obviously the institutions that are kind of running it, but then some other places in Europe have already expressed some interest. We currently have an ethical agreement that allows all of this to be done. It's in place. Any UK centres can be added as collaborators relatively easy. A lot of the big centres, there might already be collaborators on this ethics agreement because it's a large sort of departmental one. But if anyone is interested, then please do contact me and we can go about getting amendments to get centres added as collaborators, and we will start sort of sharing some detail about that. The plan is that all of the UK samples are going to be stored in the UK at Barts, and all of the continental samples are going to go to Würzburg. And then there is a PhD who's funded through a separate grant, who is, as part of their grant, is traveling between the centres anyway for a separate project. So then they will perform the analysis for this. So that's it. I'd be very happy to take any questions, mostly on DLK1.